Maybe you've come to this video because you've got a headache right now and you've already googled the word brain tumor. Now, take a breath. As a neurosurgeon who operates on brain tumors for a living, I can tell you that the odds of somebody with a headache having a brain tumor are extremely low. They're not zero, but very low. My name is Paluzzi. I operate on brain tumors for a living. And today I want to answer the question that brings more people to my clinic in a state of quiet panic than almost any other. When is a headache just a headache, and when is it something I need to see? In this video I will explain how common headaches are, how uncommon brain tumors are, and why the severity of a headache does not reliably predict the odds of having a brain tumor. I will walk you through the red flag signs and symptoms that, together with a headache, might raise the possibility that the underlying cause could be a brain tumor. What to do, the practical steps to take if your headache worries you. Now let's begin with the most important message of this video. The great majority of headaches are not caused by brain tumors. One primary care study estimated that following a new and otherwise unexplained headache, the 1 year probability of diagnosing a malignant brain tumor was approximately 0.15%. Now that's 1 in 700. In people over 50, that figure doubled to around 0.28%. That means 1 in 350. Now, those numbers should reassure you, but they describe millions of people, not you specifically. What actually matters is what makes your headache more or less likely to be one of the rare ones. How can a brain tumor cause a headache? And the explanation is not what you might think. It might surprise you, but the reality is that the brain tissue itself does not feel pain in the same way that your skin or muscles do. A tumor causes pain indirectly by affecting structures around the brain that can detect pain. Now there are three principal mechanisms. A tumor might stretch or displace pain-sensitive membranes and blood vessels. The second is that it may produce surrounding swelling known as brain edema. And the third is that it might obstruct the normal circulation of the cerebrospinal fluid, that fluid that sort of surrounds the brain, producing a condition called hydrocephalus, which literally means water in the brain. And that can increase the pressure inside the skull. Now, this is why tumor location and tumor biology can sometimes matter more than the tumor's diameter, the size of the tumor. A relatively small tumor close to a narrow cerebrospinal fluid pathway may cause substantial symptoms that suggest plumbing. A considerably larger tumor elsewhere may remain relatively silent. Faster growing tumors and tumors associated with more edema, more swelling, also appear more likely to cause headache than slowly growing lesions of similar size. So there is no simple relationship in which a larger tumor automatically produces a worse headache. And that's something to remember. Now here's where it gets generally interesting and where a lot of popular advice oversimplifies. Turn the question around. Instead of asking of everyone with a headache how many have a tumor, ask instead of everyone with a diagnosed brain tumor how many have a headache. The answer across multiple large case series is somewhere between roughly 1/3 and 3/4 of patients. Now that might sound alarming until you look at the second half of the finding. Headache is rarely the only symptom. By the time most brain tumors are diagnosed, the headache is accompanied by something else. Seizures, weakness or numbness on one side of the body, changes in personality, nausea, vomiting, swelling of the optic nerves that lead to change in vision. Now, if there's one idea I want you to leave this section with, is this. A headache does not diagnose a tumor. A pattern does. What accompanies the headache often tells us more than whether the pain is throbbing, pressing in the front or the back of the head. Now consider two hypothetical patients. The first has experienced severe migraine since their 20s. The pain is unilateral, one side of the head, throbbing and occasionally associated with vomiting. The current attacks are unpleasant, but identical to those they have experienced for many years. Now, between attacks, they are neurologically normal. They don't have any more deficits. The second patient has also noticed increasing difficulty finding words and occasionally drops objects from one hand. The first patient's pain may be far more severe, but the second patient's pattern is more concerning, and this illustrates why the intensity of pain cannot determine whether a tumour is present. Now, the clinical question is not simply how much does it hurt? It is this new? Is it changing? And is it anything neurological happening alongside the headache? These are the red flag signs to look out for. The first red flag sign is a new or changing pattern. A long-established pattern of migraine that has remained essentially unchanged for many years is generally less concerning than a completely new type of headache. What matters is not simply whether someone has pain, but whether the pain is evolving. A headache becomes more concerning when it is new, progressively more frequent, or clearly different from the person's previous headache. For example, someone who has experienced occasional migraine since adolescence may suddenly develop a continuous, non-migrainous headache that becomes more prominent over several weeks. The important feature is not that the new pain is necessarily severe, it is that the person's established pattern has changed. A new headache after the age of 50 also deserves a lower threshold for clinical assessment. This does not mean that it is likely to be a tumour. It means that the range of potential secondary causes becomes broader and should be considered more carefully. To summarize this red flag, in headache assessment, the trajectory often matters more than the intensity. A stable, severe headache may prove to be migraine. A moderately painful headache that steadily changes over time may require more investigations. Now, the second and more important red flag is a headache accompanied by neurological symptoms, particularly if they're new. These neurological symptoms can be grouped into three broad patterns. The first is focal neurological problems, such as a new weakness, a new sensory problem, or difficulty with speech or vision. The second is a seizure, particularly a first-time seizure in someone who has never experienced one before. The third is a cognitive or behavioral change, such as increasing confusion, memory difficulty, or a marked alteration in personality. Now, brain tumours do not produce one universal symptom pattern. Their effects depend heavily on where they are located. A tumour affecting what we call the motor cortex, that part of the brain that controls movement, may produce weakness. A tumour involving the language area may affect speech. A lesion irritating the cerebral cortex may produce seizures. A tumour in the cerebellum, the back part of the brain, or the brainstem, may cause unsteadiness, coordination problems, or double vision. And this is why headache is rarely considered in isolation. Across studies of brain tumour presentation, seizures, cognitive impairment, and focal neurological deficits are repeatedly identified alongside headache. The third red flag sign is a cluster of symptoms that might indicate raised intracranial pressure, raised pressure inside the head. And these include persistent nausea or vomiting, progressive visual disturbance, and increasing drowsiness or reduced alertness. Some people with raised pressure develop papilledema, which is swelling of the optic discs at the back of the eyes. This patient may notice brief visual obscurations, blurred vision, or sometimes double vision. Another typical sign of suggestive of raised intracranial pressure is a headache that worsens by coughing, straining, or bending. Once again, this is a finding that is not specific. Cough-related and positional headaches have several possible causes, many of which are not tumours. The significance lies in the combination. A headache that is gradually changing, accompanied by repeated vomiting and associated with deteriorating vision, deserves greater concern than any of these symptoms in isolation. Now, this is the principle clinicians use repeatedly: pattern, combination, and progression. And one question I get asked quite often: does every persistent headache require a brain scan? And the answer is no. Brain imaging is extremely valuable, but it is not a substitute for clinical reasoning. The decision to request a scan should be based on the history, the neurological examination, and the presence or absence of concerning features as we listed above. Scanning every person with a common stable headache would reveal very few tumours, and it tends to create more problems than it wants to solve. It would produce large numbers of incidental findings, minor abnormalities unrelated to the headache, but capable of generating a lot of anxiety, a lot of appointments, and sometimes unnecessary procedures. On the other hand, when a headache is new and progressive, when the neurological examination is abnormal, or when associated symptoms suggest a structural problem, imaging may be entirely appropriate. In non-emergency circumstances, MRI usually provides the most detailed assessment of the brain. CT scans remains particularly useful when urgent imaging is required or when MRI is unavailable or unsuitable. So, headache or tumour? Now, for the great majority of people watching this video, it's a headache. It's a common, unpleasant, entirely non-dangerous headache. The numbers say so plainly, and no amount of late-night searching will change them. But the evidence suggests that you should stop asking, what does my headache feel like? Start asking, has the pattern changed? Is there anything else? A seizure, a weakness, a change in vision, a change in balance, personality, memory? Is this escalating rather than settling? Is it getting worse rather than getting better? Now, if the answer to any of these questions is yes, well, that's not the moment for more Googling. That's a moment to see a doctor, get examined properly, and if indicated, get imaged. Not because you're likely to have a tumour, but because a 10-minute neurological examination is the only reliable way to tell the rare case apart from the ordinary one. Now, these features still do not mean that a brain tumour is present. There are several possible explanations, but they do mean that the symptoms should not simply be attributed to stress, migraine, or fatigue without a proper clinical assessment. As a neurosurgeon, my goal is not to make everyone with a headache fear a tumour, nor it is to dismiss symptoms simply because headaches are common. My aim is to place the risk in its correct proportion while recognizing the relatively small number of cases in which the pattern justifies further investigation. This video is for education and general information. It cannot determine the cause of an individual person's headache. If you have new, changing or concerning symptoms, seek assessment from an appropriately qualified healthcare professional. Thank you.